I met Dr. Chris Strear, a medical doctor, about 3 years ago at a Starbucks not so far from here when we talked about the theory of constraints as it applies to a healthcare setting. I was so delighted that he was interested in writing a book, and even more delighted that it was about his real world experiences applying theory of constraints to massively increase flow not just in an emergency department, but throughout the entire hospital. This was at a time when my dad had just suffered another stroke, and I was so grateful for the advice that he gave me at a time when I really needed help understanding how to navigate an extremely complicated healthcare system. He has since published his amazing book, Smash the Bottleneck: Fixing Patient Flow for Better Care and a Better Bottom Line. He will soon be serving as the Chief Medical Officer at Columbia Memorial, and he has some amazing observations and lessons learned that I think is applicable to every technology leader. Here's Dr. Strear.
Hi there. As Gene said, my name's Chris Strear. I'm an emergency physician in Portland, Oregon. I've been an emergency physician here for about 19 years. It was my first job out of residency. I remember, I think I was probably practicing for a couple of years, and I was starting to get an itch for what else is there that I can do besides seeing patients. I was working a pediatric shift with a resident, and it was a slow shift. And it turned out that while he was getting his MD degree, he also was getting an MBA. And I was asking him about business. I told him that I was thinking about wanting to learn more about the business aspects of healthcare, or maybe just business in general. And he suggested that I read a book called The Goal. Well, I read it. And it's no exaggeration to say that this book changed my life. Even though the book is about a manufacturing plant, every page I found aha moments about improving healthcare patient flow. And I probably read it 3 or 4 times, one right after the other. And each time I found more and more information in the book. Serendipitously, a couple of years later, I had a chance to put what I learned to use. Now, I work in a level 1 trauma center. It's an urban hospital. It's probably the closest thing that Portland has to a county hospital. We see a lot of trauma. We see a lot of very sick people. We see more methamphetamine than I ever thought existed. And around 2007, our hospital was struggling. We had unbelievable problems with flow. We were boarding patients in the emergency department for hours and hours, and sometimes days, while they waited for an inpatient bed to become available. Our hospital was so crowded and flow was so backed up that our emergency department was on ambulance diversion for 60 hours a month on average. Now, that means that for 60 hours a month, our emergency department was closed to the sickest patients in our community. One month, we hit over 200 hours of diversion. It was horrible. We couldn't keep nurses. It was such a hard place to work that nurses would quit, and we relied on temporary nurses, on agencies for placing nurses or traveler nurses to fill in the gaps in staffing. And for the most part, these nurses weren't experienced enough to work in the kind of an emergency setting where we practiced. And it felt dangerous to come to work every day. It felt dangerous to take care of patients. We were just waiting around for something bad to happen. The president of our hospital recognized how bad things were, and she put together a committee for flow. And I was lucky enough to be on that committee. And in fact, the sum total of my experience was reading The Goal. I had read one book, but that was one more book than anybody else in the hospital had read. And so I became the de facto expert, and I ended up being the director of patient flow. It was transformative. Within a year, we had basically eliminated ambulance diversion. We went from 60 hours a month to 45 minutes a month. We improved the length of stay of all of our admitted patients in the hospital. We shortened the time patients spent in the emergency department. We virtually eliminated the patients who left the department without being seen because the waits were too long. And we did all of this in a time when we had record volumes, record ambulance traffic, and record admissions. It was amazing. We took better care of patients. It was safer, and it felt so much easier to take care of patients. It was such an amazing turnaround, in fact, that we were able to stop hiring temporary nurses, and we were able to fill our staff completely with dedicated emergency nurses who were qualified to work there. In fact, our department became the number one place for emergency nurses to want to work in the Portland, Vancouver area. Honestly, I had never been a part of anything that amazing before, and I haven't been since. We made patient care better for tens of thousands of patients, and we made life better for hundreds of healthcare workers in our hospital. It was amazing. A few years later, the president of our hospital was replaced, and the new president came in and didn't see that there was any flow issue. And shortly after she started her position, she eliminated the director's position for flow. Now, it's not that I was particularly smart or particularly gifted. What I was the point person for flow. I was the one whose job it was to keep an eye on things. And when she eliminated that position, things devolved, and all of the gains that we had made over the next few years slowly eroded. The last time I looked at our data was a couple of years ago, and our ambulance diversion time had gone all the way back up to 60 hours. We had lost everything we had gained. So what's the difference? What was the difference between 2007, when the president of the hospital knew we were in trouble and did